and kratom interacts with these. So some of these different receptors mediate the opioid response to analgesia, to respiratory depression, to sedation, pain transmission, etc. So kratom contains two main active compounds that are known as mitragynine and 7-hydroxymitragynine. So they're closely related with the difference of that one hydroxyl group. Mitragynine has activity at the mu-opioid receptor, so it's going to be involved in analgesia, respiratory depression, slowing gastric motility, which is how it's used for diarrhea, and some euphoric effects. And 7-hydroxymitragynine also is active at those receptors as well. There are probably lots of other compounds in kratom that may have some effect on what we see when patients use this, but they haven't been fully described yet. These also have some activity at those other opioid receptors, so those are some of the other effects we see. And this may be why it's useful for treating addiction or opioid use disorder. So kratom has some interesting effects. In low doses, it has more of a stimulant effect. This is why people might chew leaves throughout the day. But in higher effects, we see more of that opioid effect predominating. So this is why people may use higher amounts to either treat opioid dependence or get a euphoric effect. And there are some reports of even hallucinogenic effects after really heavy use, which isn't something we see with most other opioids. So after it's used, it has a pretty quick concentration, pretty quick time to peak concentration. It has pretty long persistence in the system, although whenever we're talking about toxicology, these numbers aren't always useful because people may not be using the whatever substance we're talking about in the way that was used in these studies. So in the US, we're commonly seeing people using this 4 to 5 times a day, and they're often using it either to treat chronic pain, to treat symptoms of opioid withdrawal, or for the recreational effects of energy or euphoria or opioid effects. Adverse effects we've seen from kratom exposures, we've seen seizures. There is a risk of sudden cardiac death because there is interference with the potassium channels in the heart. So there are potentially some cases of this, although they haven't really been well described. There have been cases of hepatotoxicity, which I'll talk a little bit more about. There have been some reports of coma, some reports of psychosis. There are some deaths described. And one thing that's notable is that with an opioid, we might expect respiratory depression to be the main reason people are dying of this. And we're not really clear that kratom actually produces much respiratory depression. And that might be because of the way it interacts with those different opioid receptors. So the hepatotoxicity is rare. This is something that when it happens within 1 to 8 weeks of starting use of kratom powder or tablets. This presents a severe cholestasis, so these patients will come in with fatigue, nausea, itching skin, dark urine, and jaundice. The cause of this is unknown, and it resolved after stopping the use of kratom. It will resolve over several weeks. There also, so this is not intrinsic to this itself, but there was an outbreak in 2018 of salmonella infections from capsules of kratom powder, and this was traced to 2 manufacturers, one in Nevada and one in Kansas, and patients were getting salmonellosis from this, and there were 199 people infected, but no deaths reported, and this just comes from potentially lack of good manufacturing practices and lack of regulation and oversight on supplements in the US. So there have been, so as part of the regulatory background on this, the FDA has issued some warnings about deaths associated with kratom use. In 2018, this was a series of 44 deaths. Some of these involved other drugs. One of them was only associated with mitragynine. And there was a case series published from Colorado covering the years of 1999 to 2017 involving 15 kratom deaths, and one involved mitragynine only. When we are dealing with toxicology-related deaths, it can be difficult to tease out the involvement of one specific compound because usually people are using or have used more than one at a time, but there are potentially some cases that are mitragynine only. So testing, sorry, this doesn't show up very well, but this mitragynine and 7-hydroxymitragynine will not show up on a urine drug screen as an opioid. we can send these out for advanced LC-MS confirmatory testing and specialty labs. Those won't turn around quickly enough to help with the management of the patient in front of you, but this is something we can look at if we're investigating a patient who has unexpected results or potentially in a fatality. So interestingly, Kratom has been illegal in Thailand since 1946, and it was made illegal in Australia in 2005. Currently in the US, it is an herbal supplement, so there's no regulation of it. And in 2016, the DEA proposed emergency scheduling of Kratom after there started to be that sort of that series of deaths. They wanted to schedule it to Schedule 1, so no medical use, illegal to possess. However, there was a huge public backlash about this, and the DEA withdrew that notice of intent, and it was not placed in Schedule 1 category. This was a very interesting time in the opioid epidemic in 2016. I remember this debate going on. This was a time when there was, this huge surge in sort of the second wave of opioid deaths and very, very limited access to treatment. It was very difficult to get patients into medication-assisted therapy. There was very little uptake of buprenorphine for treatment of opioid use disorder. And so people were basically asking the DEA not to restrict access to something that they felt was useful in managing their opioid use disorder. And that was how the DEA ended up backing down. So currently, state laws vary widely. So it is not illegal federally, but there are state legislations that prevent its use or sale. So in most states, it is legal. However, so this graph is a little confusing. When it says mostly legal, it means that there are places in the state that it is not legal. So in Colorado, it's Denver and 2 other towns that don't allow sale or use of Kratom or sale or possession of Kratom, but the rest of the state does. In California, I believe it's only San Diego and other places like that. There are a few states where it's completely banned, including Wisconsin, Indiana, Arkansas, Alabama, and Vermont, but most states have no specific legislation on this. There is a nonprofit organization known as the the American Kratom Association, and they have developed legislation that can be adopted or used by different states to try to put some legislation in place for requirements of safe use, sale, and possession of Kratom, with the idea being that they want to encourage minimum legal age of purchase, safe manufacturing processes, safe label of products, safe dosing guidelines, and testing requirements of manufacturers. And several states have adopted these. So they don't ban Kratom, but they have legislation in place to regulate its sale, production, and use. So my takeaways are that we are often talking about the opioid agonist activity when we're dealing with what Kratom is doing for our patients. It may have stimulant effect in low doses, but in high doses may cause CNS depression and seizures. Some risks from it come from the risk of contamination in its manufacturing and handling, and there's that idiosyncratic hepatotoxicity that happens. We also want to warn patients not to combine metragedy with other medications that may have CNS depressant effects or with other supplements that may also be unregulated. And with this risk of seizures, we warn patients with seizure disorder not to use Kratom.
That was really, really interesting. And I know we're going to have some great discussion. Thank you, Dr. Bani. I already have tons of questions, but we'll wait till the end and go ahead and put them in the chat because we'll come back. And now I'll introduce Dr. Bott. Dr. Bott, who many of you have already met. He's done quite a few of our seminars. He's a board certified physician in general psychiatry and addiction psychiatry. Professor at University of New Mexico, and he serves as the chief of addiction psychiatry. He's currently involved in a number of federal grants aimed at improving access to and outcomes for opioid use disorder treatment. He's also actively engaged in research with psychedelics, including psilocybin and ketamine. His passions include teaching and equity in healthcare, and we love having Dr. Bott here. Thank you.
Thanks, Dr. Page. Hi, everyone. Good to see everyone. I'll pull up my slides here and continue this conversation, right? Thanks, Dr. Bani, for starting things off. And and setting everything up, I'll sort of go more into the kind of some of the clinical things that we see. So let me, with that, pull my slides up. There we go. And I'll begin the slideshow. Okay. And we should have plenty of time for question and answers at the end, which is always good. Let me just clear up my screen. So hope everyone is doing well. It is not letting me move this bar, but that's okay. We'll figure it out. As I begin, I have no disclosures to report. Okay. Can everyone see my slides? I'm curious to know. Can someone give me a... Okay, great. I see.
Yes.
Yes.
Okay, awesome. Thank you. So it's just me, like there's a bar that's right in the middle. So I will do my best to kind of negotiate around it. Hopefully it'll be a good test of how well I know my slides. So Dr. Bani sort of set this up and kind of talked about kind of the use, traditional use of Kratom, right? Where it is often fresh leaves are used, often for energy, mild stimulant effects. But we in the Western world, right, we have this obsession with, isolating alkaloids and changing up how substances are used. Like think about going from chewing coca leaves to using cocaine, right? Or think about chewing cot leaves that Dr. Bani mentioned to, using bath salts, right? Containing synthetic cathinone. So we just have this obsession of doing it. And it's sort of no different with Kratom. And I think Dr. Bani, you alluded to this, but I just kind of want to highlight this, right? Where here, oftentimes it's sort of like these capsules or powders that are sold, or even I've seen like extracts of mitragynine or 7-hydroxymitragynine, right? We've had patients using it kind of almost like lean, which was popular, right, in particularly in the South many years ago, where people are mixing it with codeine and soft drinks and or alcohol. And of course, given the lack of regulation that Dr. Bani referred to, mislabeling is a major concern, right? It's an unregulated product. Just last week, I had a patient with underlying opioid use disorder, not in treatment. When I did the intake, they pulled out a packet of some kind of an extract from Kratom with other things added to it. Who knows, like if I had it tested, and they said they went to their, the head shop, and the guy working there recommended that they treat their opioid use disorder using Kratom. So we wound up having a really long conversation about it, right? So because I'm always worried about mislabeling. So in the US, we first started seeing it despite this long history of use in parts of the world where Kratom, naturally grows, right? The Mitragynous speciosa naturally grows. In the US, we don't see it until 2007. And most of the data that we've seen, the rise in prevalence, is really after 2015, so in the last 7-8 years. And it's been reported, there's actually more and more data coming out just in the last couple of years, some really good studies have come out, expert consensus have come out, which is really adding to our understanding. Dr. Bakireva, hi. Head shop are these shops that are, you can find them all over, like even going up and down Central, that might share, like bowls or like smoking paraphernalia or different formulations of synthetic THC or vape cartridges. And oftentimes they'll also be selling Kratom as well as some of the newer cannabinoids like Delta H THC, for example. So those are the head shops, which are largely unregulated and have often formed a reason where we, oftentimes these sort of not scheduled but potentially dangerous compounds show up and people buy them from. And it's been reported, right? Henningfield out of Johns Hopkins, as well as Covey, in some of the recent studies have actually put the prevalence as pretty high of Kratom, not of Kratom use disorder, just of Kratom use, right? In some of the newer studies, they pinned the prevalence, right, as people who tried Kratom, and even up to like, this might be an outlier, but up to 6% of the population. By contrast, some of the NIDA studies have pinned it much lower, at around 1.5% lifetime use, less than 1% past year use. So my guess is that the number is probably in between, and with time, we may be seeing more people using Kratom. And in the United States, it tends to be people who are largely employed, educated, usually with at least a high school or a college degree, tend to have private age, Caucasian, middle age. And in the US, it's about 50-50 in many of the studies in terms of male-female use, versus in Thailand, for example, where from my understanding, a majority of the people who are using Kratom are male. And co-use is very common. Nicotine vaping and cannabis use were strong predictors of past year use of Kratom. So I think co-use is very common, and that's often, I think, one of concern. And people often use it, right, as Dr. Bani referred to, for opioid substitution or treatment, self-treatment, which I think I go into in the next slide a little bit. But this was a really nice kind of a survey by Kristen Smith, who's a researcher with NIDA, National Institutes on Drug Abuse. And her theory was that although some people are using it for those things, Kratom might be a little bit different from many of the substances that we think about, like substances of abuse or substances of addiction, where the process why people are using Kratom is often positive reinforcement driven. One of the things that we often teach our trainees when we're teaching them addiction medicine is that when an addiction develops, when someone becomes addicted to a substance, a state of dysphoria emerges where people are, kind of constantly feeling anxious or depressed or irritable or can't sleep. And the only way that he can get rid of those symptoms is by using that substance. That's negative reinforcement. Clinically, probably many of you have heard this. I certainly hear this every week. Patients saying, I use heroin not to get high, but to get well, or to feel well, or to feel normal, some version of it. But with Kratom, this is a little bit different. I think it's perplexing, and we need to learn a lot more about this, where the number one reason for why people were using Kratom in this survey was to feel less bad and to strive for enhanced quality of life, right? Things like boosting energy and endurance, or for relaxation or recreation, for concentration, for stamina, right? So those form major reasons why people are using Kratom. Again, different from sort of classical opioids when we see those. All those self-treating symptoms of depression, anxiety, PTSD, and chronic pain and opioid use disorder also emerged as reasons why people use Kratom. And this is something I think clinically we're all seeing, where people may be engaging in some form of harm reduction or self-treatment, where and preclinical data may bear this out, where mouse studies do show that MTG stands for mitragynine, right? The active alkaloid in Kratom. When it's been mice are given mitragynine, it reduces this administration of heroin and can also relieve opioid withdrawals. And that's what our patients are often seeing. And that's really what some of this data is getting at, that, up to a quarter of people who are regular users of Kratom say they're in recovery from a substance use disorder, and 15 to 25% have used it to treat their opioid withdrawal symptoms, or even to kind of treat their opioid use disorder in a longitudinal way. People often say it works well, it's easy to access, whereas our treatment for opioid use disorder or chronic pain is not always easy to access, right? If you think about even here in New Mexico, especially in New Mexico, that can be such a challenge. So maybe it's a path of least resistance. People also perceive it as being safe because it's natural, right? We see this. But as Dr. Bani pointed out, I agree, it's not entirely safe. I mean, some pretty serious side effects have been associated with it, and we don't know a whole lot about who might be susceptible for it, what might be mechanisms behind some of these rare but serious side effects. If you look at overall, out of all the people who are using Kratom, this is a survey of over 8,000 users, less than 1% wound up seeking medical care. Garcia Rameau, out of Johns Hopkins University, wonderful researcher, wonderful clinician, demonstrated that if it's really how often someone is using Kratom and how much they're using that correlates with the frequency of side effects. So people who are dosing over 5 grams of dry leaves, which is where you start getting some of these opioid effects in animal studies at least, and who are using, just like Dr. Bani pointed out, right, like that 3-4 times a day on a week per week basis, up to 20% of them will have some side effects. Lots of drug-drug interactions. This is what I think there was a chat going on, and I was alluding to this, that I think one of the things that I really worry about with Kratom more than even its own side effects, is how it interacts with other substances. It inhibits multiple hepatic enzymes, right? It also inhibits UGT. So medications that are metabolized through glucuronidation, such as lorazepam, for example, can interact with kratom. So if someone is using kratom and taking, someone's taking lorazepam, right, Ativan, which can have respiratory depression potential, they start taking kratom, lorazepam levels potentially go up, and the person has trouble breathing, they might have respiratory suppression. There are case reports of quetiapine levels jumping up in people when they started using kratom. And I think there's even a case report of like cardiac arrhythmias and other side effects in this association. So I think I've just included a list of things that have been hypothesized to interact with kratom. So if you have a patient with kratom, provide this education as part of engaging them in treatment. What other medications are you taking? Let's search some databases, right? Let's do some drug-drug interaction. Be really mindful, because kratom likely can increase the levels of many other medications and substances. I think clinically for me, that's a big challenge. As Dr. Bani pointed out, mortality is probably less of a concern. I think in multiple animal studies, this has been shown that kratom does not recruit. When it binds to and activates those mu-opioid receptors, it doesn't activate what's called the beta-arrestin pathway, which plays a role in respiratory suppression. And by not doing it, kratom is likely safer. And in the Henningfield, again from Hopkins, in his big review on mortality, reported that risk of death may be at least 1,000 times lower with kratom than with classical opioids. And again, the data is kind of mixed. Not a whole lot of data on kratom-related mortalities. Can it happen? I think it certainly can, but it's by itself, certainly, my sense is it's a lot less likely to lead to overdose mortality. And there's often, again, this polysubstance that I think about. When I think about kratom-related overdose, I think about what other substances may have been at play, what other underlying physiological conditions may have been at play. That brings us to tolerance and withdrawal, because we hear this a lot, right? How addictive is kratom? Is there kratom use disorder? How do you treat it? That's what I really want to focus on in the last few minutes. So I think tolerance and withdrawal is certainly possible. I've seen it. Probably many of you have seen it. But what studies show, both human studies as well as animal studies, is that tolerance and withdrawal are a lot less likely with kratom, again, compared to other classical opioids. But they can happen in humans. I've included a lot of data here, so people can use them for reference. I've also put a lot of references at the end so people can have them. Won't go into everything here, but it can happen, particularly in people who are using heavily and regularly. This was a study of heavy kratom users, regular kratom users in Thailand, done by Singh, where you can see that up to almost a third of kratom users reported tolerance. Almost 2/3 reported a history of withdrawals, right? And 89% of users actually reported having tried to abstain, quote unquote. Right? This is terminology I've taken right from the study. So I do apologize about it. I kind of always cringe when I hear words like users or, things like that. So I've taken it from the study, but I even as I'm reading it, I feel kind of cringy. So I apologize about it. So not very patient-centered language, right? Not very recovery-oriented language. But cravings tend to be less than other opioids. And if you look at all the kratom users as a whole in the United States, you can see that withdrawals are seen in about 10% of people who use, right? And withdrawals tend to be generally milder. There's also a case report for those of you who may be working with particularly pregnant individuals with substance use disorders of neonatal kind of withdrawal symptoms related to maternal kratom use. Some of the withdrawal symptoms are similar to that for other opioids, like a lot of these physiologic withdrawal symptoms. But then with kratom withdrawal, we also see this kind of emotional component, nervousness, anxiety, restlessness, anger, hostility, which may be a little bit different, although I've certainly seen it with other opioids as well. And part of it may be that kratom also works on non-opioid receptors, right? For example, alpha-2 adrenergic receptors are a well-known binding site of kratom. So kratom use disorder doesn't exist in the DSM, right? There is no such thing as kratom use disorder. But I generally, when I'm working with someone clinically, will apply the criteria for opioid use disorder. If I have a patient coming in talking about their kratom use, they're reporting kratom use, I'm going to use kind of those DSM criteria. That's generally what I'm going to do, although there is no specific kratom use disorder category in the DSM. Usually what you find is that when people have kratom use disorder, right, when they meet criteria for opioid use disorder as a result of kratom use, for a vast majority, it tends to be mild to moderate, driven primarily by those physiologic dependence criteria. This is just a little reference slide, right? So tolerance and withdrawal. If someone meets those, which as the studies have shown, many people who are regularly using kratom may, you already have a mild use disorder. So that's often what drives this diagnosis. I think it's a lot less common for someone to have a severe use disorder as a result of their kratom use in big epidemiologic studies that have been done. So moving forward, so these are some reference slides I've included from a big review that was done by Henningfield and Associates and their group, a nonpartisan, non-privately funded, non-industry funded review that evaluated kratom on a variety of things. A couple of things I want to point out here that are worthwhile. So a lot of these ones here look at kind of that reinforcing value of mitragynine. And what these studies largely show is that mitragynine is probably less reinforcing compared to our classical opioids. That's really what a lot of these animal studies are getting at. And then this one is kind of getting at prevalence. This is sort of getting at some of the things I talked about. References are included that people who are using kratom frequently may have tolerance and withdrawal, but likely less severe than that for other opioids. Then this one is really getting at, again, this mortality, right? Risk where, as I pointed out, it's likely a lot less toxic from a respiratory depression standpoint than other opioids. And the data often shows co-use with other substances. So I've included a lot of these references. So finally, I'm going to go into how are we going to work with these patients. So as usual, our patients, right, with substance use disorders who are seeking treatment for substance use, they're often highly stigmatized. They have had negative interactions with the healthcare system. So we want to cultivate a non-judgmental, curious, empathetic approach. We want to be respectful by recognizing the adversities, but also the strengths that a patient may bring with them when we work with them, and use non-stigmatizing language, something I've failed to do, right, in the last few slides, and I'm acutely aware of it. I generally will embed this question, again, very open-ended, very non-judgmentally, and ask about the use, not sue, of herbal supplements like valerian root or kratom, right? Just invite the patient to share, be non-judgmental. Understanding motives for use is important. It's going to be different for everyone. So tell me a little bit, what does the kratom do for you, for better or for worse? Just an open-ended question that I find gets me a lot of the information I need, right? I often will throw in that for better or for worse at the end because that just, again, invites the patient to share whatever their perspective might be. And again, incorporating that patient conceptualization in terms of why are we using, eliciting patient perspective, and offering, and that's our opportunity to start to offer alternatives with permission, right? So for example, if I find out that the patient's using kratom because they have opioid use disorder, then I might with permission share, did you know that we have evidence-based treatments available, right? Whether it's buprenorphine, whether it's injectable naltrexone, whether it's methadone, right? If someone's using it to self-treat anxiety, have you thought about cognitive behavioral therapy? Or have you thought about an SSRI? If it's PTSD, have you thought about trauma-focused therapy? So it allows us to introduce more evidence-based options, because remember, there is really little to no data supporting the efficacy of kratom for any of these things. Although people are using it, the perception is there. There are interventions with a lot more data. So that's often the first thing I'll do. Use that attitude, right, to provide the education. In terms of treatment, the first question I ask is always this: is there an underlying opioid use disorder? Did the person have already a history of opioid use disorder and start using kratom to stop using other opioids, right? Or has their kratom use progressed so much where now they're meeting that moderate to severe opioid use disorder criteria, although that in my experience is relatively uncommon, but it could happen. Are there underlying psychiatric conditions? The second question. And again, if yes, providing evidence-based treatment. That's the route I'm going to take. So if there is underlying opioid use disorder, then I think buprenorphine naloxone, right, is the most extensively studied intervention. There are no randomized control trials, but there are several case reports and case series which generally show good outcomes. Most reports, this is a practical tip, do have patients wait up to 24 hours after last kratom use and allowing them to go into withdrawals before they take the first dose of buprenorphine. This is from a relatively new study from Weiss in 2021, who recommended that the patients are generally taking less than 20 grams of kratom, then 4 to 8 milligrams a day of Suboxone may be a good dose for them to start and maintain. But if patients are taking over 40 grams, then you may need to go higher, 12 or even 16 milligrams of Suboxone may be a good dose for them. And generally, long-term outcomes are good. In fact, buprenorphine treatment is the strongest predictor of kratom non-use over the past year. So it's clearly doing something. This is from the Weiss study, where it shows that as sort of the dose of kratom goes up in grams of dried leaf a day, the dose of buprenorphine required also goes up. You know, intuitively makes sense, right? And really over about 40 grams or so, 16 milligrams of buprenorphine may be the optimal treatment. But if there is no underlying opioid use disorder, I don't think there is enough data for us to be starting everyone on buprenorphine. So I think really the best practice recommendation, this is from an expert panel that was recently published, it should be done, MOUD medications for opioid use disorder should be started only on a case-by-case basis, right? These may not be optimal treatments, and we may actually be increasing the tolerance. So you really want to be careful if there is no underlying opioid use disorder. Certainly provide brief interventions, educate, empower, elicit information, and help with the self-taper of the kratom. Consider using clonidine or lofexidine, which there are case reports of, and again, makes sense given the strong action of kratom on alpha-2 adrenergic system to help with symptomatic management. Use behavioral interventions, but keep following the patients and keep the door open. I will end here. I've got some references and I'll stop here so there can be lots of time for questions.
Wow. Thank you, Dr. Bhatt. Thank you, Dr. Bani. And I'm looking forward to the question session. I'll let Christina, you moderate this, please.
Okay. All right. Yes, please go ahead and
Start at the top.
if you have a question. I see a question. Is kratom ever smoked or injected? In the chat.
I don't know if anyone's smoking this because it is, you know, it's accessible if you swallow it. So usually people will go that route if that's available. I don't know, Snehal, if you've ever seen anyone smoking it. But I
have had patients who smoked it. I don't know what it did. I've actually never seen anyone who injected kratom. No. It's usually, again, the capsules or extracts that patients I've seen are taking. Curious to know if anyone here in the audience has seen anyone injecting kratom. I have seen people smoking it.
Let's see, another question in the chat. Is valerian root bad to take? It was mentioned along with kratom.
Here, I think that was my slide, so I can start things off. I think I use valerian root just as an example, right, of like how I might ask about kratom use by asking about sort of herbal supplements. I mean, I could have substituted really any herb, right? That being said, I think at least anecdotally, people will say that taking kratom and valerian root together will increase kind of the sedative effects, right? Which may make sense, but I don't know, Dr. Bani, if you know if there are any specific interactions between the two.
No, I don't know any interactions between them. Valerian is an herbal supplement that is used as a sleeping aid, so causes some CNS depression. I think we were just talking about herbal supplements in general. We need to be aware that they do have effects that we should monitor our patients for.
Okay, we've got some chats coming in. Joyce says it looked like there's a potential drug interaction with Kratom and other prescriptions, but there are no actual studies at this point, question mark.
A lot of what we know about drug interactions comes from if we know that one drug interacts with a particular metabolic pathway, we can infer that other drugs that are metabolized by that pathway will have interactions. So we don't always have specific studies on them, but we can say that if these are both using the same enzyme to be broken down, that there may be an interaction. And there have been some studies showing increased levels of drugs in some patients. I'm not sure if there's probably not a study on every one of those interactions, but there are some case reports and predicted interactions.
And that list was in Dr. Bott's slides, which we will make available. Please raise your hand too. You don't have to rely on the chat.
Another question in the chat, can Kratom be passed from mother to child through breastfeeding?
I'm not aware of any studies looking at levels in breast milk, which would be interesting to do.
I am also not aware of them.
Thank you. More
I'm muted.
questions.
I was asking, I think that again highlights, right, just simply how much we don't know. And how many more studies are really indicated. I think right now, primarily what we have are case reports, right? Case reports of like adverse effects, which are largely from poison centers, or just like case reports that people have seen, clinicians have seen, or there are case reports of treatment with buprenorphine largely. But there's really little systematic, and there are a fair amount of animal studies, but especially in humans, we need a lot more. There is a lot we just don't know. And that's always, for me, a little bit eyebrow raising, just given how commonly we're seeing.
Thank you. Other questions? Ash Sina raised your hand. Please go ahead, Ash.
I don't know if it's really a question, but it just dawned on me, or just a comment. I mean, for something that's been around and been in use in other regions for so long, and I know that the adverse effects that you're sharing are from animal studies, and mostly because, like you mentioned, there's no regulation here on how it's dispersed. If there were more studies with regulations put in place, it may one day be beneficial for the things that you're describing, opioid use disorder. And I don't know, just a comment. That's all. Thank you.
Ash, it's true. And I hear that often. Well, this has been around a long time. People use it. They use it differently. As Dr. Bott pointed out, there is an obsession with, modifying the drug so it has more effects. And then we get into really dangerous territory. There's a big difference between drinking a tea of coca and snorting a line of cocaine. Think about the alkaloids that are put in. It's an obsession that happens.
But the same thing happens though with Suboxone and methadone. People misuse that all the time to get a high. You know what I mean? So, but I definitely see what you're saying, and I agree.
Oh, the world's full of fabulous chemists, much better than I.
Thank you, Ash.
But for a while in Thailand, even after they legalized, they made Kratom illegal. In Thailand, the government gave out Yama pills, which are an amphetamine type substance, to field workers to work. So this need for drugs that improve function is still ongoing. It's just, when do you get to the point where it becomes dangerous, right? Or as we say, the risks outweigh the benefits.
Yeah, and could it be helpful, right? But potentially, I think just given right. I mean, I think to really see it through, we'd first need to understand all these things better, right? Like, what receptors is it binding? How is it binding it? And then I think the clinical studies, I think with anytime opioid use disorder is involved, I think clinical studies are a little bit extra challenging, because we have some pretty effective medications, right? So ultimately, the studies are going to wind up comparing samitragine or 7-hydroxymitragine or something to currently existing standards of care, which kind of raises the bar a little bit. But certainly, I mean, I don't want to discount what people are saying, people who are using it, and people do say it helps with their symptoms, right? So I think it's, you know, I think for me, it gives me some thought, right? Like how do we better study that in a safe way?
Okay, lots of questions coming in the chat. Have you seen that people take more kratom with a pill or with the loose powder?
Snail here. So generally with a pill, it's yeah, or extracts if people are finding those, right? Then I think that's gonna be in many ways the most, I guess, the easiest way for them to get a lot of potent alkaloids. There was one study that reported, and I've always and there, like, NIDA has actually commented on it. There was one study in particular that reported people using like crazy amounts of kratom in their case series. It was a case series that used buprenorphine to treat people who were using kratom. And I think they reported like several hundred grams of kratom. But, you know, I think that maybe, so I think the reason I bring it up is we have to think about how are we weighing it, right? Like when we say someone uses 5 grams or 40 grams, we have to standardize that. The sense is that the paper that reported these very high numbers, these very high, I think in that study, the mean was close to 100 grams, which most people aren't going to be able to tolerate. They were probably weighing the weight of the tea or whatever they were brewing from it, right? Which is very different. I think when we say 5 grams or 40 grams, we mean the weight of the dried powder. And most people aren't going to be able to tolerate more than, I think, 50 or so, at least anecdotally, of kratom before they start getting side effects and just kind of feeling crappy. You know, so and if they're brewing it into a tea, that's a whole lot of cups of tea they're drinking. So I think pills are just easier for people to get higher amounts in, right? Capsules or extracts, which are going to be even higher because now you've extracted out or in, I guess, the powerful alkaloids. That's sort of my sense. What do you think, Dr. Bani?
Yeah, my sense is that people are able to take capsules easily multiple times a day, and that's how I have seen people using it, but I'm not sure I care for as many patients who use kratom as you do.
Thank you. A couple of questions about what is the prevalence in the New Mexico population and nationally, and a part of that question also, how do we track that?
For
I don't know of any, I don't know of any prevalence estimates. I'm sorry, Dr. Bonnie, go ahead.
I was going to say for New Mexico, I don't think we track it. Nationally, it's around 1% have used in the past year, which actually sounds very high to me, but it is widely available in Albuquerque. You can go on Google Maps and look for places to buy it, and you can go see what forms it's available in if you're interested.
I see the Mountain Center Harm Reduction has their hand raised. Please go ahead.
Hey, thank you. I just had a quick response to what you all were saying about the like powder versus capsules, just from personal experience. It tastes really bad. So
I have heard that,
like
yes.
not very easy to pound a bunch of the powder. It's kind of like mate, like almost like an oversteeped mate, like really bitter and nasty. So
That
just
doesn't sound pleasant at all. Yeah.
side note on the practicality front, it's harder to take a lot of the powder.
Thank you. Another question in the chat, has there been any discussion about adding a diagnosis code for kratom use disorder?
I don't know if Dr. Bott knows about that.
None that I've heard. None that I've heard, right? I mean, you know, but I think clinically, again, I think it's good for us to start to operationalize, right? So I think how we weigh how much someone is using, I think similarly, how do we diagnose? And I think generally I wind up applying the DSM-5 criteria. to that. But there is no specific diagnosis, and as far as I know, it's not, it's not at least imminently about to get added. And I mentioned, I included some slides from that Henningfield review that kind of with a lot of references. And that was an independent review that kind of essentially compared the public health implications of scheduling Kratom versus keeping it unscheduled. And this was, again, an independent panel of experts who reviewed, a whole lot of data. And ultimately, their conclusion was that the potential harms of scheduling Kratom may outweigh the potential harms of leaving Kratom unscheduled, but thinking about sort of quality control and regulation to ensure, again, that the doses are available, are reliable, that there are no contaminants in it. There have been case reports, right? You mentioned, Dr. Bani, of the pathogenic outbreak. I've seen reports of lead exposure as a result of Kratom. So ultimately, the recommendation of that panel was to keep it unscheduled, but regulating quality and really educating clinicians to incorporate asking about it, and really trying to think of evidence-based way to address it.
Kimberly Rowlands has raised her hand. Please go ahead, Kimberly.
Yes, if I was wondering if somebody overdoses on it, can they use Narcan if there is an overdose on it?
So we talked about this a little bit in the chat earlier. We don't see a lot of respiratory depression happening with Kratom use, and respiratory depression is the indication for naloxone. So there isn't a lot of use for naloxone in these situations. I do know that there's one case report where someone did have slowed respiratory rate after Kratom use and got some naloxone, and that improved. But there isn't a lot out there on using it for these situations, partly because the indication for it doesn't seem to happen very much.
And Snail here, I totally agree. And clinically, if I know, for example, if we have a patient at our ASAP clinic that we know is using Kratom, right, periodically or regularly, and they're and I'm walking by the lobby, and this is hypothetical, this has not happened, right, and I see them, kind of turning blue, right, or having some respiratory depression. In that case, clinically, I would, of course, do the usual ABCs, right, and include using naloxone, because I think in my mind I would be thinking, is it the Kratom? Maybe, but unlikely. But could the Kratom use have co-occurred with some of the other deleterious things that are so common in our community, right? Namely, illicit fentanyl analog containing pills, right? So that would be sort of where my mind would take me, and I would wind up using naloxone in hopes that whatever other opioid there was will be displaced, and of course we would do ABCs and call 911 to get more definitive treatment.
Yeah, I want to emphasize what great advice that is. Almost all of the deaths in the US associated with Kratom involve more than one drug or substance. So certainly if someone is not breathing, we would certainly try naloxone for anyone before we make decisions about what they did or didn't have in their system.
Thank you. A comment, Dr. Correjo said she found one case report with a confirmed baby exposure via breast milk.
Thanks, Dr. Correjo. Hi.
Let's see. I think this one has already been answered. Do we know if naltrexone blocks the effects of Kratom? Not sure if our presenters have anything else they'd like to say.
I don't think we've talked about naltrexone, and I don't know the answer to that.
Snail here. Yeah, we haven't addressed naltrexone, but again, I think there isn't much in the literature. There is, I think because it's two things, right? We're not gonna, unlike naloxone, we're not gonna use naltrexone necessarily in cases of suspected overdose, right? We're gonna be thinking with naltrexone more in terms of initiating treatment. And I think I have seen case reports again, but not much. of naltrexone being used for people with opioid use disorder, who are using Kratom. So I think there has been maybe 1 or 2 case reports that I've seen, but I would have to look into that. I think majority of the literature is focused on buprenorphine. Great
Thanks.
question. Does anyone else know on that? And then in terms of precipitated withdrawal, I think there's also a case report on that in terms of people having precipitated withdrawal. But again, I think the one thing with those case reports that's always the big uncertainty for me is that were they also using other opioids? Because that is so common. And was the precipitated withdrawals as a result of naltrexone displacing the kratom, right, the mitragynine, or was it whatever other opioid they were taking? So we just don't know enough. That's kind of a cop-out answer, but that's unfortunately, like, I think really where we are in terms of the knowledge.
Let's see. Julian Trujillo has their hand raised. Julian, will you go ahead, please?
Yeah, sure. So I wanted to ask the panelists, like, on a scale of like issues like fentanyl right now, do you think Kratom rises to that level of concern for like addictions professionals? Because I work at a methadone clinic. I'm a counselor at a methadone clinic, and I want to make sure that like we're staying apprised on like what's the stuff that we need to be concerned about in our practice, what we need to be asking our clients about. Do you think Kratom rises to that level at this point, or is this kind of something we just need to keep an eye out for?
Deaths associated with Kratom are very rare, and it does have potential maybe to be used as treatment for fentanyl. So it's certainly not at the level of fentanyl. And we've seen these different trends over the past few years, starting out with prescription opioids and then heroin and then fentanyl and the semisynthetics. And Kratom hasn't shown a big increase in deaths over that time period. Overall, it's a relatively safe substance, is what I can say about it.
Snehal here, I would agree. I guess the one word answer to your question is no. I do not think this comes anywhere close to illicit fentanyl, for example. Strangely enough, like, because right, as part of my job, I also spend a good amount of time at an opioid treatment program, right? We have almost 500 patients on 450 or so on methadone at our clinic at UNM. And I almost see this as an opportunity for patient engagement, right? Clinically, that's really at the heart of, and hopefully I was conveying that a little bit, where, I'm not approaching it from a sense of panic. I don't think that the Kratom use is gonna, lead to my patient stopping breathing and dying, right? But I wanna know that it's going on, right? Because does that mean that if they're using Kratom, they're having still uncontrolled anxiety and that's what they're trying to target, right? Or are they aware of the drug-drug interactions it may cause if they're on some psychiatric medications or antiretrovirals, for example, right? So that's really where I start kind of that conversation with the idea that if it's happening, A, I want to know about it. B, I want to understand the reasons for and the perspective of use from my client. And C, if the patient allows me to hopefully engage in some harm reduction or to give some recommendations and maybe guide them towards things that may be more evidence-based. And I think that's really how I wind up approaching it. I don't know, Julian, if that answers or addresses your question.
Yeah, it does. Just to like follow up a little bit, do you as far as you're aware, do you know of any interactions between methadone and Suboxone and Kratom?
Sorry, I couldn't hear the question.
Do you know any interactions between methadone and Suboxone and Kratom?
I don't think there are any interactions between buprenorphine and Kratom. Although I think theoretically buprenorphine associated precipitated withdrawals from Kratom may happen. I don't think we know enough. Like I said, most of the case reports had people wait after their last use of Kratom until they were already in withdrawals to start buprenorphine. So could that happen? I don't know. Dr. Bani, do you know that one, or whether that can happen.
I've never seen it happen, but I don't know that I've started anyone on buprenorphine who has been using Kratom that I can think of.
And I'm not aware of any specific methadone kratom interactions either. Although again, theoretically, because methadone's got a pretty complicated metabolism, right? I think it's primarily 3A4, but 1A2 is involved. Dr. Bonnie, you're the expert in it. I probably should shut up, but I think 2C9 or 19 is also
Well,
involved. And
theoretically,
kratom does inhibit some of them. So
well, methadone has a big effect on the cardiac potassium channel, and theoretically, metragenine could also. So someone exposed to both could have QTC prolongation from these effects and could have cardiac dysrhythmias from that. But I don't know that I've seen that happen.
thank you. Right. So another reason, Julian, too, for us to be aware of for our patients, especially the ones that are on methadone maintenance treatment.
I think we have time for one more question. What impact does Kratom have on adolescents from the chat?
So Snehal here, I haven't seen again any adolescent specific data, right?
Me either.
However, we do know, again, the way I would approach it, we know the clear association between Kratom use and the use of vaping of nicotine and cannabis, right? Both of which do have a big impact, which is kind of would take a lot more time to go into on adolescent, right? Brain development, for example, like outcomes longitudinally. And I think anytime an exogenous alkaloid substance is introduced, I just worry about its effect on brain development. So that is to say, not a lot of data, but I would be concerned because with the lack of knowledge, and B, I would be asking about if there is use of other substances that we know can affect the adolescents.
That's a great way to end. And I did notice that the Mountain Center had their hand up for a long time. Please send your questions to either Dr. Bott or Dr. Bonnie. And we've got some more in the chat, but I think to respect everyone's time, we'll cut it off now. We'll send around a small survey. A small summary, as well as make the slides available. And I want to thank everyone for coming. We had a great turnout. And also, please do let us know if there's something more you'd like to hear about either in working with your patients or with adolescents or anything to do with substance use. And we will try to organize a seminar to keep us all informed. This was really brilliant, and it was nice to meet you, Dr. Bonnie. We'll be calling on you some more. Bye, everyone.
Nice to meet you.
Thank you.